Good morning. Now we will have a free paper presentation. The session will be chaired by Dr. Shiva Ilango. Welcome to the dais, sir. He is a professor in HOD Department of Psychiatry, Karpaga Vinayaka Institute of Medical Science and Research Center. Worked in variety of settings both in India and UK for past 16 years in general adult and old age psychiatric services. Assistant Professor in Psychiatry at Sri Balaji Medical College Hospital, Krompet for 4 years. Associate Professor in Psychiatry at Karpaga Vinayaka Institute of Medical Science for 3 years. Life Fellowship of Indian Psychiatric Society. I heartily welcome to this, sir. Now over to the chairperson.
At the outset, let me thank the organizing committee for giving me this wonderful opportunity to chair this free paper session. I know we are into the third and final day of the conference, so we can't expect a lot of people around that too in the morning at 8 o'clock, but still I think there are very interested doctors online and offline trying to present the free papers. So I congratulate them on behalf of the organizing team. To start with, let me welcome the first presenter, Dr. Shobana S., who is going to present on a cross-sectional study on new onset depression and anxiety among COVID-19 survivors. So over to you, Dr. Shobana. I hope you know the rules for the free paper presentation. Is it 12 minutes?
Yes.
12 minutes. And 3 minutes for discussion if any questions are there from the audience. All right? Okay, over to you.
Good morning, sir. My study topic is a cross-sectional study on new onset depression and anxiety among COVID-19 survivors. I'm Dr. Shobana from finally a postgraduate student from Department of Psychiatry, KAP Vishwanathan Government Medical College, Trichy. Introduction. The outbreak of COVID-19 pandemic has led to public panic and problems for the world's public health and generates mental health problems. Due to the dramatic measures accompanying isolation and uncertainty about future and fear, adverse psychological outcomes are common in COVID-19 survivors. Recent case reports and observational studies have suggested that COVID-19 patients are likely susceptible to developing depression and anxiety. These disorders should be adequately diagnosed and addressed by clinicians to improve prognosis, decrease the length of hospital stay, and avoid long-term mental health issues. Previous studies have shown that hospitalization in intensive care units and the use of mechanical ventilation are both risk factors for developing acute psychiatric symptoms. COVID-19 patients who require intensive care could potentially become a high-risk group for developing psychiatric disorders. Aim. This study aimed to assess depression and anxiety in COVID-19 patients discharged from hospital. Methods. A cross-sectional study was conducted among 100 discharged patients who were hospitalized for COVID-19 in KAPV Government Medical College, Trichy from 20th April 2021 to 20th May 2020. Study instrument, a semi-structured questionnaire containing the socio-demographic data, generalized anxiety disorder 7 scale, patient health questionnaire 9 scale was given. Participants completed a telephonic interview. Depression and anxiety was assessed using patient health questionnaire 9 and generalized anxiety disorder 7 scales respectively. Patient health questionnaire 9. Patient health questionnaire 9 consists of 9 items measuring depressive symptoms corresponding to the diagnostic criteria for major depressive disorder. Each item is scored on a 4-point Likert scale with scores ranging from 0 to 27, with higher scores reflecting greater depression severity. Scores above 10 are considered to be in the depressive area. Scoring 0 to 4 none, 5 to 9 mild, 10 to 14 moderate, 15 to 19 moderately severe, 20 to 27 severe. Generalized anxiety disorder 7 scale consists of 7 items measuring worry and anxiety symptoms. Each item is scored on a 4-point Likert scale, 0 to 3, with total scores ranging from 0 to 21, with higher scores reflecting greater anxiety severity. Scores above 10 are considered to be in the clinical range. The GAD-7 has shown good reliability and construct validity. Scoring 5 to 9 mild, 10 to 14 moderate, greater than 14 severe. Inclusion criteria: COVID-19 positive patients admitted in MGMGH Trichy, age more than 15 years, those who agree to participate in the study and give an informed consent. Exclusion criteria: past history of psychiatric illness, patients not willing to give consent. Study center, patients who were hospitalized for COVID-19 in KFTV Government Medical College and MGMGS Turkey, sample size 100, sampling method, convenient sample. The discharge patient list were taken from COVID-19 box, samples were taken up to the same sample was reached. Duration of study 20th April 2021 to 20th May 2021. Data collection, all data were collected through telephonic interview. Data analysis, SPSS software version 16 was used for data analysis. Results, the study was conducted in 100 COVID-19 positive survivors, and this pie chart shows a prevalence of anxiety among participants using GAD-7 score, and it shows 59% of them had anxiety symptoms. And this is the table showing association between anxiety and socio-demographic variables. And here there is a positive statistically significant correlation with age group, marital status, and duration of hospital stay. There were 66 to 75 years age group has higher proportion of anxiety symptoms compared with other age groups. A higher proportion of married participants had anxiety symptoms than unmarried. A longer stay in hospital, 16 to 20 days for COVID-19, has higher proportion of anxiety symptoms, as the association shows significant statistical results. And this bar chart shows prevalence of depression among participants using patient health questionnaire 9 scores. And it shows a 66% patients showed mild symptoms and 21% patients showed moderate symptoms. Table 3 shows association between depression and socio-demographic characteristics. And it shows statistical significant association with age group, gender, and marital status. The age group of 66 to 75 years had higher proportion of mild depression than others. And 75% of males had mild depression, 43.8% of females had moderate depression, and this association is found to be statistically significant. 69.6% of unmarried participants had mild depression, and 27.3% of married were under moderate depression, and this association is statistically significant. Correlation between duration of hospital stay and GAD score. There is a positive correlation between them. As duration of hospital stay increases, GAD score increases. Correlation between duration of hospital stay and patient health questionnaire score, and there is a positive correlation. As the duration of hospital stay increases, PHQ score increases. Coming to discussion, this study aims to assess the new onset depression and anxiety in COVID-19 survivors. 66 to 75 years age group has higher proportion of anxiety symptoms compared with other age groups. A higher proportion of married participants had anxiety symptoms, and the longer stay in hospital is positively correlated with anxiety and depression. 75% males have mild depression, 43.8% of females have moderate depressive symptoms, and this is association with statistically significant. 69.6% of unmarried participants had mild depression, 27.3% of married were under moderate depressive symptoms, and found to be statistically significant. Among COVID-19 survivors in North India by the SA et al. Study, 44.54% of them had anxiety and 61.34% of them had depression, and the age group more than 50 years were likely to show symptoms of anxiety and depression. And this was similar to our study, as older age groups are more likely to be affected with anxiety and depressive symptoms. The study supports that there is a need for mental health education and rehabilitation measures aiming to reduce the impact of COVID-19 pandemic. The impact of COVID-19 on psychological well-being is highly significant. Further research regarding psychological impact of COVID-19 might be useful to implement the necessary actions. The cause of these symptoms is likely multifactorial. One possible factor is lack of contact with families and loved ones during hospitalization, fear relating to the disease due to poor knowledge or misinformation regarding to COVID-19, and social stigma may also facilitate the development of these symptoms. Hospitals should implement remote mental health screening programs and psychiatric consultations using technologies such as telemedicine, establishing a system allowing proper communication between hospitalized patients and their families. These are my references. Thank you.
Thank you, Dr. Sobana. That was an excellent presentation. I wonder if there are any participants online wanting to have any question. All right there, okay. Anybody from online participants have any questions on this study? Well, let me ask a couple of questions. In the meantime, people have time to think what to ask Dr. Shobana. That was a well-conceived study. I think that is the need of the hour right now, where we deal with COVID over the last 1.5 years. So many patients with a lot of problems. And certainly mental health issues are on the rise. There is no doubt about it. So you made an attempt to study the psychological morbidity post-COVID, so which is very, very relevant. Do you have any comment on the sampling method? You said about convenient sampling, is that right? Yeah, I'm just wondering, like in Trichy Medical College, to my knowledge, in the second wave, if you take both April and May, there will be thousands of patients who was admitted with COVID. You could still get all the list and you could have randomized. That will give you a better sense of understanding. That is one of the suggestion, because it's possible.
Okay.
Yeah, and the second thing is about, yes, we do a telephone survey. Probably this is the only way we can do it, because we can't expect patients getting discharged from the hospital after, say, 10 or 15 days of admission to come back for these kind of studies. So that is obviously a limitation for us. But even then, if you could give us like how many patients you have contacted over telephone, how many attempts were given before you leave that, no, this person is not picking up, so I'll move on to the next one for inclusion in the study. So that probably the flow chart, so if, for example, if you have attempted to study 150 patients, out of which 50 patients didn't pick up the phone, and maybe another 10 persons didn't give consent. So that kind of breakup, that will add more value to your study. It's as if that, yeah, you have made it. You would have done it, but I think it will be appropriate you mentioned it over here as well. All right. So certainly very, very, I think, useful findings in terms for all of us. Yes, we know that anxiety and depression are on the rise, but to quantify them. So thanks a lot, Dr. Shobana. Any questions from any audience? I'll just give another 1 minute. Okay, then I think thanks, Dr. Shobana. We'll move on to the next presenter.
Thank you, sir.
So next in line for free paper presentation, Dr. Cherao, a case series on the relationship between anorexia nervosa and obsessive-compulsive disorder in adolescence. So I welcome Dr. Sean to start the presentation.
Thank you, sir. Am I audible, sir?
Yes, you are.
Am I audible?
Yes, yes.
Okay, thank you. Is my screen visible, sir?
It's visible, yeah, go on.
So can I start? Morning, everyone. I'm Dr. Sean, a second year postgraduate in the Department of Psychiatry from St. John's Medical College. I'll be presenting a case series on the relationship between anorexia nervosa and obsessive-compulsive disorder in adolescence that I had come across in my recent child psychiatry rotation. This is being done along with my mentors, Dr. Suhas, Dr. Vidyaraman, and Dr. S.M. Manoj. OCD and eating disorders, they have a similar age of onset, a similar course of illness, comorbidities, and genetic loading in familial studies have been noticed. Psychopathological similarities such as obsessions related to food or eating patterns and compulsions associated with food restrictions is the psychopathological similarity that is noticed. They have common neuropsychological impairments in terms of the cognitive abilities that are involved. The neurobiological hypothesis involving the serotonergic system is seen in both conditions. Personality traits such as perfectionism, especially concerns about mistakes, doubts, overactions, meticulousness, as well as rigidity. Individuals with comorbid eating disorders and OCD develop the eating disorder at a younger age and experience a more chronic, unremitting course of illness as compared to individuals without a co-occurring OCD diagnosis. Coming to the case series of 4 children, the first was a 14-year-old girl studying in 10th standard, who was a slow to warm child, rigid and stubborn and perfectionistic traits in her temperament, with a family history of OCD, obsessive-compulsive personality disorder, and depression in the mother, with a history of suicide in the first degree relative and marital discord in the parents. presented with restrictive food intake, increased physical activity since the last 1.5 years, unstable vitals, as well as low mood, decreased interaction, and irritability. Presented with a weight loss of 15 kgs, uh, uh, presented with a weight loss of 15 kgs with a BMI of 13.5 and an average caloric intake of 200 to 300 calories. Uh, she also presented with contamination obsessions with cleaning compulsion and a CY box score of 26, high family accommodation with preoccupation with academics. And the trigger was fat shaming by the peers and fathers. The second girl was a 13-year-old girl who was studying in her ninth grade, temperamentally easy child and stubborn, family history of a psychiatric illness and a second-degree relative. Presented with a similar complaint as the previous child, except that this child had endocrine disturbances such as amenorrhea since the last 8 months, and the duration of presentation was for 1 year, with a weight loss of 8 kgs, a BMI of 16.2, and an average caloric intake of 700 to 900 kilocalories. Also presented with contamination obsessions with cleaning compulsion and a CY box score of 22, along with preoccupation with study. The third child was an 11-year-old girl who was studying in a 7th standard, temperamentally an easy child, perfectionist, stubborn, and very particularly the just right phenomenon was seen in this child, with a family history of psychosis in the mother, which is treated, psychosis in the paternal grandfather, anorexia case in the father, and with an average academic performance. Presented with the same complaints since the last 1.5 years, with unstable vitals, low mood, decreased interaction, and irritability, with a weight loss of around 14 kgs, a BMI of 10.5, and an average caloric intake per day of around 200 calories. The child also presented with she avoided swallowing her spit. There was also an absence of the mother's role noted in the parenting of the child, and with excessive preoccupation with studies. The trigger was fat shaming by her peers as well as father. The last child was a 17-year-old girl who had completed the 12th standard. Temperamentally unencastic traits were present. Significant rejection sensitivity was present. With a family history of depression in both parents were currently on treatment and unencastic traits in the father. Presented with a restrictive type of food intake for 2 years, along with low mood and decreased interaction and death wishes since the last 1.5 years. Had presented with a weight loss of 8 kg and a BMI of 16.2 with an average caloric intake of 700 to 900 calories. History of an MS family, involvement of the extended family in the dynamics, as well as preoccupation with academics, was found to be inflexible and extremely circumstantial. The triggers were the need to be perfect. So what these cases had in common? If you look at it, they had particular eating behaviors. That is, the anorexia nervosa restrictive type of eating behavior was noted, and specifically food neophobia was noted in these children. In terms of it is defined as the attitude towards food, that is, they could have the same type of food 3 times a day without being bothered by it. The temperamental traits commonly seen among these cells that they were perfectionistic, rigid, and inflexible, as well as stubborn. A family history of psychiatric illness was noted among all of the children, and a most common psychiatric comorbidity noted in these children were OCD and mood disorders. The children that presented were sort of able to exert control over one's diet habits before coming to the hospital. They were the ones who had a say in their diet, and this is how the parents found it very difficult to manage the child at home. Multiple dietary misconceptions in terms of the size of the food, the calories that are associated with food, and every child in particular said that anything with fat is possibly bad. They had excessive preoccupation with studies. With this, all their focus and attention is either going on, it's completely on studies, and there is a complete lack of awareness to the rest of the environment. So these were the most common, these were the most, or the commonalities that are noted in each of these cases. So why do we need to discuss it? So firstly, to see if anorexia is a covariant of OCD or not. The specific temperamental traits such as inflexibility and stubbornness, perfectionistic as well as excessive doubts, as well as the treatment challenge. So coming to is anorexia a variant of OCD or not? A dysfunction of the neurocircuitry is implicated in compulsivity. It can be seen across both anorexia as well as OCD. Models of neurocircuitry involved in compulsive behavior suggest that the involvement of the corticostriatal circuit consisting of a striatal as well as a prefrontal component. The striatal component is seen as responsible for driving compulsive behavior, while the prefrontal component controls the inhibitive behavior. So abnormalities in either of these components may result in an increase in compulsive behavior. Abnormalities in the neurotransmitter activity has also been noted, such as dopamine, glutamate, and serotonin are seen across both the disorders. In individuals with anorexia nervosa, dietary restrictions tends to take on a driven and a compulsive quality. So the compulsive behaviors seen in anorexia nervosa have often been compared to those of OCD, but with the obsessional focus being on eating, weight, and shape. The core feature that unites both anorexia nervosa and OCD is the compulsive nature of the disorder, and that is a specific behavior. Compulsive weight loss behavior such as persistent food restriction, over exercise is a prominent feature of anorexia, and it is parallel to the compulsive behaviors characteristic of OCD. So such parallels reflect the similarities in the underlying mechanism that poses a transdiagnostic approach between anorexia and OCD. There is also a pharmacological overlap between OCD and eating disorders. A phenomenological overlap between the OCD and eating disorders. That is, the repeated checking of the shape and weight can be viewed as analogous to checking windows, doors, etc. And repeatedly seeking reassurances about one's body shape is akin to repeated reassurance seeking in OCD. So the ritualistic behavior that accompanies eating in patients with anorexia uh, can be viewed as similar to the ordering compulsions that occur in the context of OCD. And the most common, of interest, the most common symptoms of OCD in patients with eating disorders are those of symmetry, order, as well as arrangement. In anorexia nervosa, it is also noticed that the behavior that is seen, the compulsive behavior, as well as the distress related to having to eat the food is ego-syntonic as compared to patients in OCD who get these repetitive thoughts. They consider these thoughts to be ego-dystonic. Finally, in anorexia nervosa, it has been suggested that perfectionism leads the patient to view adherence to food restrictions as success in the context of perceived failure. Most recently, it has been argued that eating disorders are the expression of perfectionism in the domain of eating, shape, and weight, and their control. The need for control has also been emphasized, particularly for patients with anorexia nervosa. So what are the treatment challenges that were faced in all of the 4 children? So firstly, the medical complications. 3 out of the 4 children presented with unstable vitals. The need for a pediatric intensive care was required, and the child needed to be seen by the psychiatric as well as the pediatric team regularly. Investigations had to be done every third day, especially with respect to electrolytes, serum, magnesium, phosphorus, as well as calcium to rule out any refeeding syndrome that was noted. A need for a complete restriction on physical exercise, keep the child warm was required at all times. The psychiatric comorbidity, that is particularly OCD as well as mood disorder, made it even more difficult to engage the child. There is no clarity on whether one should approach the OCD or one should approach the anorexia nervosa while the child is during the inpatient stage. There is no clarity if ERP should be started with the child when the child is in the inpatient as an inpatient in the hospital, or if it has to be started on an outpatient basis, and one should completely concentrate on the eating manifestations that are known. Involvement of a family was a big challenge while it came to the treatment of these children, particularly to do with their misconceptions alone. That was number one. Number two was the presence of the psychiatric illness in the family members resulted in high expressed emotions as well as family accommodation in the behavior of the child, which made it difficult for us to engage with the child as well as the family members. Thirdly, their understanding of the illness itself, which made it difficult for them to engage with the child. Fourthly is managing countertransference and maintaining rapport in terms of the fact that the child viewed us as the fact that the child saw us as somebody who's taking away whatever control they had over any particular domain of their life made it difficult for us to sort of maintain rapport with the child. It was the first day we would have rapport with the child, and then the next day when we increase the caloric intake with the child, it made it even more difficult to engage with the child in further sessions. So one of the challenges is definitely maintaining rapport and managing that countertransference with the child. Thank you.
Thank you, Dr. Sean. Actually, your audio was a bit unclear, but it doesn't matter. I think it was loud, but I don't know whether you are presenting from a phone. Is that right?
I'm presenting from a laptop.
Laptop, okay.
Yes, sir.
All right. I'm just open the presentation for any comments, questions from the audience. Dr. Shan, I'm
Yes,
just
sir.
interested to find out all the 4 cases in your case series were
Yes, sir.
collected over a duration of like is it months
3
or
months,
years?
3 months, because our child rotations are generally for 3 months. So within those 3 months, I had the opportunity to see four children with anorexia who were treated as inpatients.
So 3 months duration. Okay. So well, that is really interesting to know, because 3 months duration, you have 4 patients with anorexia nervosa symptoms in a medical college setting. I think it just says that it's quite common, or it's probably in adolescence at least. These are
Yes,
becoming more, prevalent, and maybe, it has come to your attention, but a lot of patients in the adolescent age group are not coming to the attention. So it is very much down there. Good.
yes.
In terms of, I think, your observation, I think, is there anything new that you have found out from seeing all these 4 patients of anorexia nervosa? Because whatever you have mentioned about the medical complications, comorbidities, family involvement, I think they are there for very much. That probably is the one that makes this whole disorder quite complex and challenging to treatment.
Yes, sir. Particularly what I found new was the food neophobia per se, as well as the preoccupation with studies. All of these children had they had sort of they had a predominant type of an eating behavior where they would sort of uh, they would prefer eating the same type of food for 3 times a day, and that wouldn't bother them at all. They wouldn't mind eating the same food for even the whole week 3 times a day. That was one thing that was definitely peculiar in all of the 4 subjects. And number 2 was the preoccupation with studies. All of the children presented with excessive interest in studying, the need to perform really well, the need to spend at least 8 hours a day for studying. All of these children presented with the same complaints, and all the parents had the same complaints, saying that it coincided with the duration of the presenting complaints. So I feel that stems down to the temperamental traits of the child to be perfect, the just right phenomenon, the need to be in control.
Right. And what are the contamination obsessions you have found in your patients? What contamination thoughts?
So the contamination obsession, when the CY box was administered to them, the contamination obsessions were that of germs. All of the children presented with repetitive hand washing, along with the obsessions of the fear of contracting infections and the fear of germs was the most predominant contamination obsessions that were there.
Right. Okay. Lovely. I think we'll move on. Thank you, Dr. Shan. If there
Thank
are
you
no
so much.
questions, we'll move on to the next one. I would like to invite Dr. Sanket Katakond. I don't know if I pronounced the name correctly. Forgive me if I'm wrong. So I welcome you, Doctor. A cross-sectional study to assess chronotypes and sleep patterns in medical postgraduates in Hyderabad. Over to you, Dr. Sanket.
Sanket sir,
Yeah,
share your screen sir.
good morning, everyone. I'm Dr. Sanket from IMH Hyderabad, and my study title is a cross-sectional study to assess chronotype and sleep in medical postgraduates in Hyderabad. Coming to introduction, chronobiology deals with the biological rhythms. 3 human chronotypes have been described in humans. They are like morning larks, evening owls, and indifferent. They are defined by their preferences for activity realization during a particular period of the day, with better alertness during morning or evening, or without any preferences respectively. Medical students on an average sleep only for 6 hours when compared to an average of 8 hours in normal population. Quality of sleep influences factors like learning and humor. Very few studies have been done in postgraduate medical students. This study aims to evaluate relationship between chronotype and the sleep quality and diurnal sleepiness in postgraduates pursuing various medical and surgical branches in different medical colleges in Hyderabad. Coming to a review of literature, Lara and others in 2020
good.
in their study in shift workers concluded that the effect chronotype has on sleep duration and a person's napping behavior depends on the shift type. In 2016, Owens and others in their study in adolescents found a significant association between self-regulation and both chronotype and daytime sleepiness. Gabriella et al. In 2013, in a study in medical students, found a negative correlation between the scores of MEQ and PSQI, indicating the more the eveningness, the poorer is the sleep quality. But they didn't find any correlation of chronotypes to daytime sleepiness. The aim of the study being a cross-sectional study to assess chronotype and sleep in medical postgraduates in Hyderabad. And objectives are to measure the frequency of morningness and eveningness in medical postgraduates pursuing various branches in different colleges of Hyderabad, and to study sleep quality and daytime sleepiness in study population, and to analyze the association between chronotype and sleep. The study tools being morningness eveningness questionnaire, which is a self-assessment questionnaire consisting of 19 questions used to measure the circadian rhythm. And next is Pittsburgh Sleep Quality Index. It's also a 19 question. This scale contains 19 questions, which is a self-rated, gives 7 components. The third scale is the Epworth Sleepiness Scale. It has 8 situations rated from 0 to 8 and helps subjectively measure a person's daytime sleepiness. It is a non-randomized cross-sectional study with medical postgraduates being the subjects, and inclusion criteria are postgraduates of all 3 years pursuing MD or MS in any medical college in Hyderabad, both males, females, and others, age ranging from 18 to 60 years, those who have given informed consent, and exclusion criteria being existing severe psychiatric illness. The study sample size is 74 postgraduate students studied over a period of a month in Hyderabad. And the data was collected through Google Forms after ethics committee approval. Coming to result and discussion, the study was conducted in 74 postgraduates from various colleges in Hyderabad using Google Forms. The mean age of the study group were 28.03 plus or minus 3.37 years, where 68.91% were females and the rest were males. And the residential details, half of the study population stayed with the family and least stayed with the stayed alone. Marital status, 56.75 were never married, and coming to working hours, 56.75% worked for around 40 to 60 hours. Results of the 3 scales, like PSQI, it showed 52.7% demonstrated poor sleep quality, that is a score of more than 5. In MEQ, 56.75 were indifferent, 24.32% were morning hours, and 18.91 were evening hours. On Epworth Sleepiness Scale, 31.08% had mild
What is it? 1, 2,
sleepiness
3, 4,
problems.
5, 6. Huh?
Severe sleepiness problems were found in 6.75%. Significant negative association was found between working hours and PSQI scores, which indicates poorer sleep quality in individuals with longer working hours. And significant negative association was found only in the individuals working with 40 to 60 hours, probably because of the adequate sample size. And this is the chart showing the same with the p-value. And negative correlation was found between the scores of chronotype questionnaire and PSQI. it suggests that eveningness was associated with poorer scores in PSQI, and p-value being 0.0329. This is the figure showing the same. And also, negative correlation was found between component 1, which is sleep quality, subjective sleep quality, and component 7, that is daytime dysfunction in PSQI, with the scores of MEQ with a significant p-value. And the graph showing the same thing. However, no significant association was found between the scores of Epworth Sleepiness Scale and MEQ. The results are consistent with the findings of Gabriela et al., who in a similar study in medical students in Brazil found negative correlation between the scores of MEQ and PSQI. Also, no significant difference were observed between the evening, indifferent, and morning groups in terms of age. Conclusion: chronotype showed significant association with quality of sleep and evening individuals showing poor sleep quality when compared to morning and indifferent groups. Higher prevalence of poor sleep quality and excessive daytime sleepiness was found in medical postgraduates. The negative correlation was found between working hours and sleep quality. Coming to the strengths of the study, it's a first of its kind in the Indian context. Assessment done in postgraduates who encounter frequent stressors in their periods of residency, and the limitations were small sample size and restricted age range. To scope of the study, further studies relating to sleep and chronotype can be done in other populations with varying socio-demographic background, and there is no conflict of interest. And these are my references, and these are the scales used. Thank you.
Wonderful, Dr. Sanket. Lovely study. I think, like you said, we don't have many studies about research on sleep patterns. So
Yeah.
I think you have done a wonderful job about, at least to start with, in postgraduates. Any questions from the audience?
Stop your screen, sir.
Okay, I'll just start the discussion. Let us have some couple of minutes discussion. This is just to make some comments, Dr. Sanket, just to improve the study methodology, right?
Yes, sir.
One thing, yes, you have done an online survey using Google Forms.
Yeah.
So what is the response rate actually? Can you calculate the response rate? That's tough,
Like,
isn't it?
yeah.
Because
It
you
is
have done
around,
through WhatsApp.
Yeah. Like
So
it is around 20 to 25% is the response rate.
probably. But how will you calculate? Because that is the problem with the WhatsApp. Like, it rolls on to a lot of people, and which you are not aware where, these kind of forms been forwarded to. Yeah, your intention is to study only the medical postgraduates. And can you filter out people,
Like, yeah,
non-doctors?
yes, sir. Like we forward it only to the medical postgraduate groups and like individual postgraduate students
Okay.
after collecting the numbers.
So your rough estimation will be like 20-25% response rate.
Yeah. Like in the group, like when we sent like a group consisting of 100 or 200 people, only like around 10 to 20 have responded.
And particularly when you're trying to study from medical postgraduates and on this kind of aspect, you could have, how did you arrive at 74? Why do you have to stop with 74? Is it the time limit that restricted you to have this sample size, or you could have got more? Or this is the only postgraduate
sir.
responded in Hyderabad? the number?
Yes, sir. Like it was the time limit basically, and like if more time was there, like more than a month, then I could have
Probably, yeah.
think I could have got more samples.
Excellent. Okay. And one more thing, yes, you have found out now there are people who are working for longer hours are likely to have poor sleep quality. What can you do with that? Can you take this finding back to the participants somehow? Is it possible?
Yes, sir. Like it is possible because the individual in the Google Forms we'll get the individual values also, like each individual's values.
So you can
those who yes, sir. Like those who are having poorer sleep qualities, we can contact them and deal with the issues.
Okay. I think you can, it's not like you have to go individually, but if you can just share your findings in the, probably in the same WhatsApp group that you have sent the Google Forms, people will know that, it's not about them, it's about the postgraduates, how they suffer and what is the link between having long working hours and poor sleep quality index.
Yes,
and if possible, I would suggest to go on one more step, send it across to all the policymakers or the deputy superintendents of a hospital or deans, vice principal, whoever you can access to. So let them have these findings and at least they can properly, make the rota so that people don't force to work for long hours, which probably affects their sleep quality. All right.
Sure.
Okay, this is just a suggestion. Because we have found something, and why don't we share with the relevant people to act on them?
Yes, of course.
Okay, all right, nice. Thank you, Dr. Sanket. Well, let's move on to the next one.
Thank you.
Okay, may I now invite Dr. D.S.N. Niresha for the next presentation on social media usage and its influence on academic performance in engineering students. Over to you, Doctor.
So can you hear me, sir?
Yeah, you can start, yeah.
Good morning. Myself, Dr. Niresha, secondary psychiatry PG from NRA Medical College. The title of my paper is Social Media Usage and its Influence on Academic Performance in Engineering Students. Introduction. Evolution of...
Excuse me, ma'am. Ma'am, your voice is not clear, ma'am.
Now you can hear me, sir?
Just a minute, ma'am.
Sir, can you hear me now, sir?
Ma'am, go ahead, ma'am. Yes, ma'am, go ahead.
Introduction. Evolution of internet technology has led its use as the best medium for communication, whereby 2/3 of the world's internet population uses social networking or blogging sites, thus serving as a communication and connection tool. Social networks include websites and applications which allow users to share content, ideas, opinions, beliefs, feelings, and personal social and educational experiences. They also allow communication between a wide range of users worldwide. Instagram, Telegram, Facebook, Twitter, Skype, and WhatsApp are the most popular and commonly used virtual social networks. Students are one of the most important users of virtual world and social networks worldwide. There are many positive effects associated with the social media users among students related to their academics. Students can connect with the various educational groups related to their field of study on social media and can easily access all the important and authentic information shared by others. Overuse of social media has a negative impact on students. Reduced academic performance is one of the most important consequences of social networking overuse for students. An Indian study showed that internet and social networking addiction had a negative effect on academic performance and the mental health of students. Another study on Ferrari students showed that grade point average was lower among students who were addicted to social networking compared to other students. Aims and objectives. To understand the perception of students toward the usage of social media, to study the impact of social media usage on academic performance among engineering students, and to determine the effect of usage period of social media on the students' academic performance. By details and methods. To This is a cross-sectional study done among engineering students of Anarchist Variant. Data is collected through online Google Forms. The assessment tools used are social media engagement questionnaire, which includes 5 items, and social media addiction scale, which includes 25 items, and academic performance self-assessment questionnaire. And the scales used were reliable and valid, and social demographic data including name, age, sex, year of the study, and grade point average of the student is also collected. Participants from the first to fourth year of the study and they were provided with explanation of the purpose of study, and they were asked to participate voluntarily after obtaining their consent. Collected questionnaires were sorted, reviewed, and unfinished questionnaires were excluded. Then all completed data were coded and analyzed. Analysis was done by using statistical package for social sciences software version 22. Results: out of 214 students, 63% agreed that they connect with friends using apps like Facebook, Insta, WhatsApp, and 26% strongly agreed that they use social media apps for connecting with their friends. And 33% of the students admit that they have a poor communication with their friends when they don't access the social media apps, while 33% also disagreed about this questionnaire. And 69% students believe that their social media has a connective power, and 55% agreed that social media networking sites are instructive, and 67% agreed that the new media has changed their learning habits. And when regarding the social media usage period, 57% admit that they use social media 15 minutes before going to sleep, and 41% admit that they use social media immediately after waking up. And while 14% admit that they don't, only 14% admit that they use the social media while having breakfast or lunch. Coming to academic, 3% students admit that they have difficulty in concentrating on studies, and 58% admit that they don't find any difficulty in finding a quiet place to study with no distractions, but 42% admit that they have trouble in finding a quiet place to study, and 46% admit that they are not able to study effectively, and 40% also said that they're attending classes which they are not interested in. And regarding time management, 40% students admit that they are having trouble in managing time to study, and 30% students admit that they are having low motivation. And to know the association between social media addiction and academic performance, Fisher's exact test is also applied, and a p-value of 0.0170 is obtained, showing a significant association between these two variables. Similarly, Fisher's test is also applied between social media engagement, scale, and academic performance self-assessment, and the p-value of 0.03 was obtained, showing a significant association. Discussion. From this study, most of the students admit that using social network sites helped them in their personal lives and communicating with friends. Results indicated positive perceptions of students towards using social media in learning. Majority of them agreed that new media technologies have changed human lives and have a connective power. Most of studies believe that social media is very instructive nowadays. Only few students admitted that spending on social networking sites affected their study time. Similar to Gilbert et al. Study, results from the current study also showed negative impact of the social media on academic performance of students. Manjur Kaular's study reported that increase in duration of time spent on social media has a negative impact on concentration and effective studying. The current study is also showing consistent results with the study, and results showed that there is statistically significant impact of student purpose of using social media on academic performance. Limitations. As the studies of cross-sectional design, it was not possible to explain the causal relationship between variables of social network addiction and academic performance of students. In the current study, the data were collected by self-reporting method that could have affected the accuracy of results, and the total sample of the students study was from students from only one university, so the findings may be of subject of generalization issues. Conclusion. Social media have a dual impact on students' academic performance. Students should try to create a balance between social media use and their studies so that they do not get distracted while studying. When using social media, students should try to use it more often for education purposes, such as acquiring or sharing information, seeking help from classmates or professors to get their doubts clarified. Hence, if you use it effectively for constructive purposes, such as learning or sharing information online, social media can prove to be a helpful tool for students. On the other hand, excess social media use can seriously affect their academic performance. My references.
Thank you, Dr. Neresha. I think the message was quite clear. The social media is a double-edged sword. So as long as you use it appropriately, it can be productive and helpful. Otherwise, it can negatively impact one's physical and mental state. So I just want to find out from you about the methodology you have chosen to study this particular subject. Because if I remember from your aims and objectives, you mentioned about perception, impact, and there's one more thing. Would it not be appropriate to use a qualitative study design rather than a quantitative design to study the perception or the impact among students about using social media network? That's my suggestion. Have a think about it, right? And did you have any idea on the prevalence of people addicted to social media from your study? No, yes?
30 to 40%.
Prevalence was not been one of the objectives, isn't it?
Sure.
Okay, all right. And is there any particular reason why engineering students were chosen?
Actually, it is many studies were conducted on medical students, UG students. So that's why.
Okay, right. Thank you, Dr. Neresha. We'll move on to the next presentation. Thanks a lot. May I now invite Dr. Amit Kumar Kalaji, okay, right. So, on impact of COVID-19 pandemic on psychological well-being of chronic kidney disease patients. Over to you, Dr. Amit Kumar.
Am I audible, sir?
Yes, you are audible, and the slides are visible. You can start.
Okay, sir. Good morning, everybody. Title of my today's paper is Impact of COVID-19 Pandemic on Psychological Well-being of Chronic Kidney Disease Patient. Author is myself, Dr. Amit Kumar, and under Dr. Madhu Sansar, Associate Professor of Bangalore Medical College. Background of my study is COVID-19 pandemic has had a global impact on patients with CKD because the CKD patient has to balance the challenges associated with COVID-19 while ensuring the continued care cannot be compromised during this pandemic era, and also stress beyond the coping mechanism of patient may result in major depressive disorders and anxiety disorders in chronic illness patients like CKD. There is a possible link has been established between chronic stress response, patient have an altered peripheral immune system with impaired cellular immunity, and also have increased level of pro-inflammatory cytokines, which may predispose the patient for depression and anxiety. Thus, depression and anxiety are common comorbidities in CKD patient. Thus, our study is aimed to evaluate the psychological effects of COVID-19 pandemic on this group of patients especially. Literature review, the study done by Go et al. Is a cross-section study, that is a mixed study, used to evaluate the mental status of hospitalized CKD patient with COVID-19 and how it relates with the presence of biomarkers of peripheral inflammation. And he found that significant about 62% patient reported depression under PHQ score, and also anxiety around 59 in general anxiety disorder scale 7. And also the correlation has analyzed to revealed, but there is no any significant relation between the psychological assessments and inflammatory indicators. Come to our methodology. The source of data is we collected data from the chronic kidney disease patient with COVID-19 positive status and which are admitted in our COVID ward Victoria Hospital, which was a specialized COVID treatment center. Our study is a cross-sectional study which has study period was September 2020 to June 2021. It was done in Victoria Hospital. The analysis were done on SPSS software which were analyzed. What were the inclusion exclusion criteria? We included age 18 years and above, and both male and female included, with both chronic kidney disease patient plus who are positive by RT-PCR COVID-19, and also they are stable for the interview. And exclusion criteria: minors who are under 18 years and unable to consent, and also who are organic or mental disorders with no any previous history of any psychiatric illness. Materials used in this study are PHQ 9 score by Chronic et al., which has a score of 5, 10, 15, and 20, which represent mild, moderate, moderate severe, and severe depression respectively. And also we use GAD-7 score, which has mild, moderate, and severe anxiety with a score of 5, 10, 15 respectively. We also collected blood samples to know the biomarkers of leukocyte count, platelet count, neutrophil count, lymphocyte count, monocyte, and C-reactive proteins and D-dimer levels. Our result showed there in PHQ 9 that mild depression were about 6 patients and moderate were 14 and moderately severe 1, and they constitute about 21% of 21 patients. And GAD 7 we have mild anxiety of 10 patients and moderate anxiety were 9, and which constitute around 19 of the total 71 samples. And we also analyzed various inflammatory markers with depression, anxiety. With in depression, the mean age was around 53 years, and their hemoglobin was 10, and neutrophils were 76, and neutrophil lymphocyte ratio was 5.4, and D-dimer were more than 1, and CRP were more than 35. And also in anxiety patients, there was a total leukocyte was 7,200, and neutrophil were 73, and lymphocyte were 17, and lymphocyte ratio was 4.7, and D-dimer was more than 1, and also CRP levels were more than 23. Now come to the conclusion of my study. There we took a sample of 71 patients. Were taken up for the study. The mean age of the whole CKD patient was 50 years. Majority patients were more than 40 years of the age time of the assessment. Male were outnumbered the females, and more than 40, that is around 40 patients, have reported psychiatric comorbidities either in the form of depressive disorder or anxiety disorders. But depression was slightly more prevalent than in anxiety. In most cases, depression was of moderate severity, and very few patients had severe depression. In terms of demographic and correlate, there no any significance of relevance, and also there is no any association we found between the GAD and PHQ 9 with peripheral biomarkers. Limitation of my study was the sample of study was relatively small. We come to the future direction. It is important in our routine care to continue our psychiatric consultation in spite of pandemic to avoid any arise in further any COVID-related psychiatric morbidity. Thank you. These are my references.
Excellent. I think, thank you, Dr. Amit Kumar, for your presentation and work on this area. Is there any particular reason why you chose, because we all know that COVID-19 has profound psychological morbidity among even normal population, but what made you to choose to look into the psychological morbidity of CKD patients in particular?
Sir, because as CKD stated is a chronic inflammatory condition, and also we know that COVID-19 itself has it is an inflammatory condition, so both can predispose the psychiatric comorbidities. So we took the studies.
But the problem here is how will you know that whatever the stress or the anxiety and depression the person having is related to chronic kidney disease or COVID-19?
this can be done by further studies like we can compare, we can do the case control studies like we can take COVID-19 patient plus CKD and versus pure CKD patient. We can compare both. Study can be further done.
Probably that is the, that will give you some idea. Is that right?
Idea, sir.
Okay. All right then. Thanks a lot. Any questions from the audience? If there are no questions, then we will move on to the final presentation for this session. I invite Dr. Harini Nagaraj for the next presentation on a case report on complex partial seizures presenting in background of alcohol dependence syndrome. Over to you, Dr. Harini.
Good morning, sir. Am I audible?
Yes, ma'am. Continue, ma'am.
A case report on complex partial seizure presenting in the background of alcohol dependence syndrome. Alcohol withdrawal seizures are usually generalized tonic-clonic seizures and usually present within 12 hours and 72 hours after abrupt cessation or reduction in alcohol intake. Withdrawal seizures are usually singular or occurs as a brief flurry of seizures over a short period. Altered timeline of presentation and semiology of seizure in alcohol withdrawal must warrant a further detailed evaluation to rule out the possible structural and or infective etiology. Hereby, I present a case summary. A 47-year-old male, known case of alcohol dependence syndrome, presented to OPD with the complaints of craving, fearfulness, and recurrent seizure after a week of abstinence. During the course of examination, patient developed seizure with the semiology of uprolling of eyes, followed by involuntary movements of bilateral upper limbs, which lasted for less than a minute and was not associated with loss of consciousness or involuntary micturition. Patient was admitted and detailed history was collected. Detailed history revealed patient had epigastric pain, palpitation, profuse sweating, fearfulness, and restlessness before the onset of seizure. And the seizure semiology of involuntary movements of jaw, involuntary movement of upper limb, uprolling of eyes, and sudden loss of posture was noted during prior episodes. Hence CT brain and EEG was ordered, and both were found to be normal. But patient was found to be anxious and fearful during serial MSCs in the hospital stay, and so MRI brain was ordered. MRI brain revealed bilateral mesial temporal sclerosis. Neurology opinion was obtained, and the patient was started on tablet carbamazepine 400 mg as it was a complex partial seizure. And patient recovered well, and his anxiety was reduced following the intake of tablet carbamazepine. Alcohol withdrawal seizures. There are many withdrawal seizures in alcohol dependence, and seizure is one among them. The usual presentation is that generalized tonic-clonic seizure, which usually occurs within 12 to 72 hours of withdrawal. Alcohol causes intoxication through the effect on diverse ion channels and neurotransmitters, including GABA A receptors, particularly those containing delta subunits that are localized extrasynaptically and mediate tonic inhibition in methyl D-aspartate receptors. Alcohol withdrawal seizures. Alcohol dependence results from compensatory changes, including internalization of GABA A receptor, which allows adaptation. Withdrawal seizures are believed to reflect unmasking of these changes and may also involve specific withdrawal-induced cellular events, such as rapid increase in the alpha-4 subunit containing GABA A receptor that confers reduced inhibitory function. This results in firing of neurons, which leads to the generalized tonic-clonic seizure. Moving on to temporal lobe epilepsy. Mesial temporal lobe epilepsy is the most common epileptogenic lesion encountered in patients with complex partial seizure. Seizure arises from mesial temporal lobe, characterized by auras such as epigastric sensation, déjà vu, anxiety, and unpleasant smells. Autonomic features like tachycardia, flushing, and pallor are common. Auras may be followed by impaired awareness and manual and oro-elementary automatism. Conclusions. Even though alcohol withdrawal seizures are common, not all seizures in alcohol dependence or withdrawal seizures. Detailed evaluation on seizure semiology for areas is necessary. Complex partial seizures may be provoked by ingestion of alcohol, as a chronic alcohol usage is an independent risk factor for seizure. Hence, our case highlights the need for detailed history taking regarding the seizure semiology and timeline in substance dependence patient, which might change the course of treatment and rule out the superimposed organicity. These are my references. Thank you.
Very short and sweet presentation, Dr. Harini. Thank you very much.
Thank you, sir.
I think you made it clear that how important the history taking in psychiatry, particularly to evaluate the symptoms present at the time of admission or presentation. Excellent. So any questions anybody has? May I ask you whether if the seizures, in your history you mentioned about history of recurrent seizures for the last 1 week or prior to the admission. Has the patient had seizures prior to that? Because mesial temporal sclerosis, I believe, would have been present for many years, if at all from childhood. So did the patient had any seizures prior to, say for example, months or years prior to the presentation?
No, sir. Patient had no previous history of seizures during childhood. Patient developed seizures only when he stopped consuming alcohol. So it was treated as withdrawal seizures for past 10 years. And as patient developed seizure in the OPD, we saw it to be not GTCS. So further detailed evaluation was done, sir.
Because complex partial seizures are always very difficult to identify, particularly for the family members and the relatives. They don't pick it up as easily as what they notice with generalized tonic-clonic seizures. Probably, detail, or sometimes we may have to ask them, few of them to corroborate if to make conclusively say that it's not present prior to the onset of alcohol. But having said that, yes, alcohol can trigger, and particularly that is the case in your patient. So it's completely two different entities which has probably triggered the onset of the another one. Okay. Thanks you very much, Dr. Harini.
Thank you, sir.
Let's move on to, sorry, I think we have one more session, presentation in this session. Dr. Nurul Huda. May I invite Dr. Nurul to do the presentation on a study on social and emotional loneliness and its association with psychological well-being among undergraduate medical students.
Good
Welcome,
morning,
Dr. Nurul. Yes.
Can you hear me, sir?
Yeah, please.
Are my slides visible, sir? Hello?
Yeah, visible, yeah. Continue.
A study on social and emotional loneliness and its association with psychological well-being among undergraduate medical students by Dr. Nurul, final year postgraduate of KP Medical College, Trichy. Introduction. Loneliness is defined as a situation in which a person experiences a subjective deficiency of social relationships in a quantitative and qualitative way. There are two distinct types of loneliness: a deficiency of close and intimate relationships leading to emotional loneliness, the lack of network of social relationships leading to social loneliness. The transition from school to colleges is a crucial event in the life of students and is associated with social, structural, and behavioral changes. This study focuses on loneliness and its effect on psychological well-being. Loneliness is emerging as a critical issue impacting students' lives. Aim. This study is aimed to identify social, emotional, and total loneliness among undergraduate medical students, and also to assess the association of loneliness with psychological well-being among undergraduate medical students. A method. Cross-sectional study was conducted in August and September 2021 among 300 undergraduate medical students studying from first to final year in KPV Medical College, Trichy. Participants completed an online questionnaire that had socio-demographic data, social, emotional, and total loneliness were assessed using De Jong-Gierwell scale, whereas psychological well-being was assessed using psychological general well-being index. De Jong-Gierwell scale, this 11-item scale. Each item is scored as none of the time, rarely, some of the time, often, and all the time. None of the time and rarely are considered to be negative response. Some of the time is considered to be a neutral response. Often and all the time is considered to be a positive response. Among the 11 items, 6 items measure emotional loneliness, for which the neutral and the positive answers score 1. 5 items measure social loneliness, for which the neutral and the negative answers score 1. Total loneliness is the sum of emotional and social loneliness. The emotional loneliness score is valid only if there is no missing emotional loneliness score. The social loneliness score is valid only if there is no missing social loneliness score. Total loneliness is valid only if the sum of missing emotional loneliness score and the missing social loneliness score equals 0 or 1. Psychological general well-being index, it is a 22-item scale. Each item has multiple choice answers with scores ranging from 0 to 5. The total score ranges from 0 to 110. Higher scores indicate greater psychological well-being. Inclusion criteria. Undergraduate medical students from first year to final year in DAY3 Medical College, age group between 17 to 25 years, and the students who are willing to participate in the study and give the informed consent. Exclusion criteria. Students not willing to participate and students already diagnosed with psychiatric disorder. Study center. Undergraduate medical students from first year to final year of DAY3 Medical College, Cherao. Sample size. Sample size was 300. Duration of study, August and September 2021. Data collection. Data collection was done through online professional data analysis. SPSS software version 26 was used. Results. This study was conducted in 300 undergraduate medical students, among which 150 students were male and 150 were female. 72 students were from each year, and equal number of males and females from each year were selected. The upcoming table shows the frequency and percentage of emotional, social, and total loneliness in the students. From this table, as we can see that the emotional loneliness accounts for about 6.7%, social loneliness accounts for about 8.7%, total loneliness for 26%, and no loneliness for about 58.6%. This is the pie diagram showing the same. Loneliness among various years. Cross tabulations were done to compare emotional, social, and total loneliness among various years. So, from this table, we can see that emotional loneliness accounts for over 40% in first year, which is highest when compared to the other years. Similarly, social loneliness accounts for about 38.5% in the first year, which is highest when compared to the other years. Total loneliness also accounts for about 34.6% in first year, that is highest when compared to other years. So there's an increase in percentage of emotional, social, and total loneliness in first year undergraduate students when compared to second, pre-final, and final year undergraduates. Comparison of psychological well-being among various years. Post-hoc test was conducted to compare the psychological well-being. So from this table, as we can see, the psychological well-being scores of the first year when compared with second, pre-final, and final year, there is a significant difference. That is, p-value is less than 0.05. So, as we see that in the first year students, there is a significant decrease in psychological well-being when compared to second, pre-final, and final year students. That is, p-value is significant, less than 0.05. Association of loneliness with psychological well-being. T-test was conducted to find whether there is any association of emotional, social, and total loneliness with psychological well-being. From this table, you can see that the psychological well-being of persons with either emotional, social, or total loneliness when compared with the psychological well-being of that with persons of no loneliness, there is a significant difference in p-value, that is less than 0.05. From this diagram, we can see that when persons with loneliness, whether it is emotional, social, or total loneliness, the psychological well-being score is less than that of the persons with no loneliness. So there is a significant decrease in psychological well-being score when there is loneliness. P-value less than 0.05. Discussion. In this study, it is found that there is a significant increase in loneliness in the first year undergraduate medical students when compared to other years. There is significant inverse association of loneliness with psychological well-being. That is, when there is loneliness, there is a decrease in psychological well-being. There is decrease in psychological well-being score in the first year students, which corresponds to increase in loneliness in the first year students when compared to other year students. Here are my references. Thank you.
Thank you, Dr. Nurul. I think it's a very important study, particularly with relevant to medical undergraduate students. And it's not surprising to find out that the first years are probably feeling lonely compared to the final years. But I just wonder, like, in your study, there is a kind of, pattern where it evolves. First years are lonely in the total loneliness score. Second year, they are better. But again, when it comes to the third year, compared to the fourth year, they became more lonely. Was there any explanation from your side as an investigator? Why do you think there is a dip in the or increase in loneliness score in the third year compared to the second year?
Sir, maybe when there is increased study in other reasons for loneliness, maybe not adequate social interactions with other members and frequent fights with the roommates. Even when they are more socialized towards a single person, they might have they are thinking that they are giving a far, or maybe comparing with others.
Fine. Probably I think I can recall from our own study in our institute where when we tried to assess the level of stress, perceived stress among medical undergraduate students, probably this was probably a very similar finding where the pre-final years are more stressed compared to the second year. Probably that implies that first years they are lonely, second years they probably get to used to that environment and the undergraduation course, so they feel a bit brighter. But when it comes to the third year, they really feel the pressure that yes, we have missed so much and there is something to achieve in the final year, so the bit of pressure comes on. And probably they try to cope in the final years with a lot of support. So probably that's the only explanation I could think of, but well done. I think this is a very important study. I probably take these findings to back to your students and try to fill in with some coping mechanisms.
We have already started taking measures, sir. On behalf of Mental Health Day on 9, 10 and 11th of October, we have started sessions, counseling sessions for first year, second year and pre-final and final year, sir.
Wonderful.
We have organized that. On future, I've already given a proposal to college institutions so that they can create a committee consisting of a psychiatrist and other members. In college, at least they'll be available for at least once a week, so that students can come to us, and then it will be better way than the students coming to psychiatric hospitals. It will be a better way if the psychiatrist goes to the college, and then there will be a better interaction, so that we can say that we are always available for them, even when they feel loneliness or depressed. And recently, like many undergraduate medical students are committing suicide due to loneliness and depression. So we are more available to them. We can say that we are available to them anytime, and you can call us anytime.
Yes, these kind of small studies definitely give some kind of insight into what should be done for students at the time of admission. And I'm sure with a lot of colleges and institutions now take up this, and they have included psychiatrist and the role of psychiatry and probably stress management as part of the induction as well. When the students join in the first 1 month, they give a bit of induction about what to expect, how to take care of their mental health as well. So which is a nice step forward. So thanks, Dr. Nurul Huda, for your presentation. Thank you. So with this, let me conclude this session for this final day, for this session. So hopefully we'll have the next session in few minutes to start with. Thank you.
Thank you, sir.